it confused me because of how it described innominate movement, but I think it's just going to take repetition. I felt like I kept thinking about it backwards. I don't know.
Tell me a little bit. How were you thinking about it?
Okay, let me pull up that page because it was saying it bases the innominate. I guess I always think about the innominates in relationship to another, whether that is a posterior or an anterior rotation. And it kind of talks about their rotation in terms of flexion or extension, and that didn't make a lot of sense to me.
Yeah, this is a gymism, and it kind of comes from anatomy terms. And how you think about it is that the pelvis is actually an extremity. It's not part of the spine. So the innominate is an extremity bone. So its flexion extension matches that of what the leg is doing. So let's say I'm in almost a toe off in late stance. That's going to be the innominate. It's going to be rotating anteriorly, but it's going to be a innominate extension.
Okay, well that makes sense.
I read my mind whenever I think about it, and I read it that way. I got to immediately plug it in my mind. So, okay, anatomical terms. What's the leg doing? An anterior innominate is an extended innominate. Hey, Eric. We were just talking about innominate position and defining extension of the innominate and flexion of the innominate. And so, like in terms of what we're talking about with last week, is that even though the innominate can be flexed or extended, and one of the models of stabilization is that no matter if it's flexed or extended, it's still nutated relative to the sacrum. So you can think of the innominants as being, you're comparing the left innominate compared to the right innominate going this way. Let's say this is my right hand. Okay, it's going anterior and it's extending during gait. This one is basically going forward and, basically flexing because I'm going this way. Now, with that, the sacrum should stay nutated on both sides within there in the stabilization model. And again, I always preface this with this is one model. There are many models of stabilization. So if you have a different model, happy to talk about it. So always think of in terms of how you're thinking about a KD is innominate to innominate. There is also innominate to sacrum where you can be talking about that nutation or counter nutation moment. So what's L5S1 doing if we have let's say we have the innominate's going anterior. So we're in late state, we're late phase stance. The innominate's going anterior, the sacrum's going with it. What is the relative stress, what is relatively occurring at the facet joint L5S1 on the right, the extending leg?
Should be extension on that side because you're going to start to develop that right rotation of the spine.
Yes. So you can think about it driving an extension force. So, if we're looking at maybe a back pain in runners, that may be one of the things we look at. We have an extension moment going on with that late phase stance, especially we have that sacrum nutated. So the sacrum's locked in, it's nutated relative to the innominate. The innominate is going anterior or into extension. From there we can have an L5S1 stress. And I often see that in runners who linger in latent stance. So we're talking about Chris 2 weeks ago with a triathlete, and it's one of the things we chatted about is that they say the foot, they have a low cadence rate or they have a long stride length, they'll drive into that extension moment a little bit more with that. And there can be variable things they do to deload that. One could be unlocking potentially to get the stress off of it. Does that part make sense?
Yeah.
It's just what I'll try and do with these two is relate it back to two things. One, motion and function. And two, what we're going to try and do is wrap it into a bit of exercise and movement so that you can study all these motions and think about them in this lab or this collective of here's a model. But then it's okay, when does the rubber hit the road? What do I need to do when I have to go to clinic? And how do I apply these principles of load transfer? So we can think of that load transfer model now. We're going through swing phase. We're approaching the ground contact phase of the innominate, and my heel, I'm going to get the heel strike. In this model, my innominate is now going to be posteriorly rotated or flexing. Okay, sacrum still nutated within that locked mechanism. Foot hits the ground. What happens next in that system? What should the innominate do? Or should there be motion at the sacrum and innominate? This can be debatable depending on your school of thought. And Again, that's why it's great to get Eric's thoughts on it or anyone else's. Chris, you have a vast amount of experience and knowledge. What happens at that moment of initial ground reaction force? Okay, Tony, come out of the dark. Tell me something. Teach me something, Tony.
What do you want to know?
Okay, my heel hits the ground. What's happening at my pelvis? Not mine in particular, maybe a pelvis and model, but if you want to think about mine, I'm fine with that.
So at heel strike with gait, what's happening at the pelvis, you said?
Yeah.
So the innominate should be in posterior rotation at heel strike, correct?
Yep, which would be relative flexion, Katie.
Yep.
Correct, yep.
Good, so what's the SI joint do? So now we're talking about innominate on sacrum.
Right.
It could go forward, it could go back, it could immediately rotate, it could do nothing and hopefully stay locked.
Right.
So what would be desirable?
Desirable
Yeah.
would be to, well, to stay locked so it can allow force transmission, correct?
That's right. We want the SI joint to stay stable position to allow force transfer from the lower extremity to the pelvis and upper extremity. Okay, I hit the ground now with my heel, and let's start with the SI joint. My SI joint gives. Okay, so let's say now all of a sudden I hit the ground. Now I get this nutation or slipping motion at the SI. And one way I like to think about this is very similar to maybe in the first module, Scott may have described it. I don't know if you did the rotation tests looking at spinal stability and control, where it can kind of rotate you this way and see if you can break the rotation and see if there's any give in that initial motion. And where Jim uses that as to show is, can you stabilize a segment? If that segment gives, then you know there's a bit of slipping or a motor control issue at that segment. And now if I'm strong, now let's say you test basically my ability to control you pushing me from my right side down to my left. And you have me here and you push and I give and buckle there. But you bring me down into this position and now you push me here and I'm stable. Well, in one position I'm weak. In the next position, those muscles are stable. The muscles can't be both weak and strong. So the model is that there's basically a control deficit at that segment. In this case, you kind of compare it, looking at lumbar spine or thoracic spine. So let's think about the SI joint as almost having the same moment, that where now all of a sudden I'm loading in heel strike. Maybe I get this innominate shifting as I create load transfer, creates a small aberrant motion. So I lose motor control. I could be relatively stuck in a let's say it's an SI joint subluxation model, and now I'm stuck in a counter-nutated position on that side. So maybe that's creating my problem. I'm stuck in the position I shouldn't be in. Or again, there's one model to say I'm stable in that position now. So now I'm transferring load because I am subluxed. So not to make things confusing, but you can always put in the back of your mind, what is the list of things that could be occurring at this segment? And can I go through this list in a systematic way to kind of determine which one it is? So back to that again, is I hit the ground with my heel, I get innominate, again, counter nutates with the force, so I lose load transfer at that segment. I have an aberrant motion there. Does that make sense? So I have failed load transfer occurring there. So what are all the cool things I could see when that happens? And you've seen it in all your patients. Person hits the ground. What's the thing you think is going to happen at the pelvis when I have failed load transfer?
Contralateral hip drop or hip internal rotation.
Yep, exactly. What else?
Left foot forward, right toes, curl, and press.
Oh, come on, you've seen it 100 times. Somebody hits the ground, they get wonky.
Most of your weight, yeah, 2 shoes.
Possibly a lateral trunk shift.
Yep, you can, and again, you can almost get sorry, you can get a Trendelenburg either way. So they could be collapsing toward the opposite side. My right heel hits. We're talking about the right side hitting the ground. I go to the left, or I can have a compensated Trendelenburg, where they actually know it's going to happen, so they're already going back to the right side to shift their center of mass over the femur, take the load off the glute med, and kind of unload it. And so you can have a Trendelenburg or a compensated Trendelenburg that goes on with that. So you have shifts throughout the spine. Upper spine can occur. Cool. What does the knee and hip look like if you're looking at them in a sagittal plane anteriorly?
Which one? That one? Doesn't have too much.
What do you think they're gonna look like? Again, it's a model, so you're not gonna be wrong. Just throw something out there.
Power off.
Chris Gray, come on, buddy. Give me something.
12%.
Give me something with words.
You're muted.
Internal rotation of the femur, medial knee glide. Sorry about that.
Yeah, you can see all that, right? So you have this larger internal rotation moment of the hip can occur.
Yes.
The whole system can fail. So kind of what we're left with the problem there is figuring out, okay, you know, we're approaching this from an SI joint model. Now, I'm not convinced that the SI joint, again, personally, I'm not like, oh, it's the SI joint doing all of this. I think the SI joint can lock to due to a myriad of things. For the fellows out there, we're looking at the ankle, we're looking at the hip, SI joint, lumbar spine, TL junction, mid-thoracic spine, potentially. We could be up at C7, and we could be up at T2 in the fellowship model. And that's kind of where you should be at level 8 and 7. We'll go into that. But today we're going to focus on pelvis.
The part that I'm getting a little confused on personally, I hope I'm not getting too remedial, is so I see the ilioposterior rotation or flexion at initial contact. But then the next question is what happens at loading response as you're moving towards mid-stance phase, and that's where I personally get a little mixed up. I mean, I'm assuming you're going to have to be coming out of that position of posterior rotation, moving towards anterior rotation.
Yes.
But I couldn't put that into words exactly what's going on at the SI joint. I don't know if I'm the only one.
If you think of the ilium and sacrum, you know, the model is that it should stay relatively nutated to not get to slipping. But if you're talking about ilium to ilium, which is where it all gets confusing because it's always, okay, which reference point am I using? Ilium to ilium, okay, yeah, I'm striding, so my right one is posteriorly rotated or flexed. I'm going to load into the ground, and then I'm going to get this derotation couple. Now, they used to get into a lot on right, left on left of the sacrum within the innominate. I'm not big on that per se, and the trend actually in AOMT and other organizations and IFOP has been to move away from the language of right on left on left rotations. So again, it's a good model to have. It's a good thing to think about. I think if Eric is doing 5, he's probably going to go over it, which is cool because to not feel like, okay, I don't feel there's the value there. What I want to do to know I don't think there's a value there in learning it is that I need to really understand it. And then occasionally I need to be able to use it. So even though I'm not a big right on left on left guy, do I look at it in my pelvises? Yes. And do I apply it? Do I manipulate ILAs? Yes. You know, but that model itself is not one that's burned into me that I use, like, you know, oh, well, this is right on left torsion. I need to figure that out per se. You know, the model has somewhat been simplified, and it's kind of been a bit more of the trend, and these trends move back and forth. But being in a manual therapy program, it's good to get the more in-depth approach, and then you can always bring it back down. So I think learning the right on right and left on lefts is good to know it. I just don't throw the baby out with the bathwater, as it were. So back to your question. Go ahead, Eric.
Yeah, so as far as the right on right, left on right, et cetera, the different sacral torsions, the reason that I think they're valuable to know is for exactly what Dave's been talking about is gait. Because what we tend to see with gait, if you're thinking about that heel strike position, so if the right leg is going toward heel strike, swinging forward, going into a nominate flexion or posterior rotation, however you want to describe it, what tends to happen is that right sacral base will come back with the innominate. And the reason is that the sacroiliac joint's non-weight bearing at that point. The sacroiliac joint's weird because it actually is more mobile when you're bearing weight on it.
Yes.
But the reason that we think that is because of that intra-articular ligament. It's really just a big fibrocartilaginous pad. It acts almost like a sponge. When you put weight on it, it compresses, and now we have the ability of that to move, right? When it's non-weight bearing and we have this kind of distance and it's kind of at its full height, it's much more tense. So it allows less motion. So once the weight bearing, once that heel strike hits on that right side, now instead of being in what we would consider a right on left, so the axis of motion is what you're naming that by, so it's facing to the right on the left axis. What you're seeing there is you're going to start transitioning from the left axis of movement to the right axis of movement as you start weight bearing on the right. Does that make sense? Where you're transitioning from a non-weight bearing position to a weight bearing position, the way that the sacrum starts to move transitions from it being on this axis to being on this axis. So that tends to be the only reason that I really kind of hold on to that stuff, is because if you have somebody that comes in that's a runner and they're how you want to go about treating that is kind of up to you. I use a lot of muscle energy technique for that stuff. You can go about doing it directly by doing ILA techniques or doing sacral base techniques. That works just fine because all it does is kind of tilts the corners. And that'll tend to still kind of correct those things. Torsions in general, I tend to think of as more muscular lesions than articular lesions, just because I tend to envision most torsions are being caused by lumbar problems, whereas innominate rotations I tend to see as being a cause of a result of long leg or some sort of thoracic lesion up above that. That's the model that I've kind of adopted. And like I said, I think last week, I've never really had it drive me in the wrong direction. But in general, if you're having a hard time maintaining correction of an innominate rotation, there's a decent chance that there is a sacral torsion there, and then you have to go in and investigate that sort of thing. So at least having it in the toolbox for these stubborn lesions that you run into is a good idea, because if you just sit there and keep pounding away on trying to correct some sort of innominate rotation and it's not holding up, it looks good by the time you're done with it, but it's not maintaining over time, being able to go back and rethink things and say, okay, if it's not just an articular lesion, there could be some muscular aspects to this. So you try and correct the muscular stuff. That, like I said, tends to lean me more toward a torsion. So I think that's a good way of thinking about things, is at least having that possibility in your head so that you can kind of deal with these ones that are more stubborn and harder to get rid of. Sorry, Dave, go ahead.
Could you repeat that one more time? You said if it was a torsional issue, you're looking at lumbar dysfunction coming from above, and if it's more of a rotational issue, that's more of a long leg, short leg dysfunction?
That's the way I see it, is that a pure innominate rotation, something where we're seeing this sagittal plane dysfunction, I will tend to think is being more driven from below, right? So if we look at the idea of having a long leg issue on, say, your right side. So say you've got a stiff hip, you've got a UFR, you've got somebody with a capsular lesion, something like that. It's going to limit hip extension, correct? That's going to end up creating what we call a functional long leg, right? So it's going to push the leg up into the pelvis. That will tend to anteriorly rotate the innominate as it does that. Once you go into, when you should be going into hip extension, it's going to kind of push you into that innominate extended position as well. I tend to see that a ton with hip problems. I tend to see it a ton with ankle problems. You tend to see it with subtalar joint problems, things like that, things that can kind of artificially drive that leg upward. Very similarly, when you have a thoracic lesion, and we've been talking about this for the last couple of weeks, when you have a thoracic lesion, whether it's a facet lesion or whether it's a rib lesion or whether you have what we consider those ring lesions, those intersegmental lesions, it tends to affect the muscle tone of those long thoracic paraspinals, like the iliocostalis, for instance. Iliocostalis is just exactly what it sounds like. It goes from the ilium up to the costal angle, right? So when you have those sort of things and it pulls tight on that, it's going to elevate one side of the pelvis, right? It's just going to pull up on that as that muscle pulls tight. That's going to leave you with basically this direct innominate rotation, because all it's going to do is tilt the pelvis forward. It's not going to affect the sacrum because it's not attached to the sacrum. That makes sense? But when we're dealing with a torsion, because of the effect that tends to occur to the multifidi, the inhibition that occurs to the multifidi, and because of the hypertonicity that we tend to get from the psoas, it tends to create these rotational issues because of the pull on the transverse processes and whatnot. Now, the sacrum is going to mimic the spine in those sort of situations because essentially it's just a very big vertebral segment when you think about it. So that's when you're going to start to see these more oblique, these more diagonal lesions. And again, it's more caused by the muscular component or the functional component with something like gait or running, as opposed to just a pure positional fault or some sort of, let's see. That's the way that I view those sort of things. So if I have somebody that comes in with SI joint problems, either SI joint pain or trouble with loading across the pelvis, you know, even something like just pain on weight bearing in that area, that sort of stuff, you know, any of the typical illness script stuff that you get with somebody that comes in with SI joint dysfunction, you're gonna, the way that I'll go about it is I'll do a screening exam for the thoracic spine, which is just seated rotation. Are they limited? For the lumbar spine, which will just be my lumbar active range of motion. I may end up going into quadrants depending on how substantial any of the limitations I find are. I'll do hip quadrants, and then I'll do ankle motions. And then if I start to find limitations, significant limitations in one area versus the other, I can start to determine, well, am I leaning more toward an innominate rotation, or am I leaning more toward a sacral torsion? And that'll really guide my initial treatment technique, you know, because essentially then, like I said last week, I'm usually looking at sacroiliac dysfunction as a secondary problem. Outside of kind of those three main risk groups that you get, pregnant women, kids under 12, and people with systemic inflammatory conditions, stuff that's chewed up that cartilage pad and destabilized the SI joint and allows it to fixate because of that increased neutral zone. And then, you know, allegedly severe trauma will fall into that category as well. I don't tend to buy that because you're more likely to end up with like an actual pelvic fracture than you are to truly damage the sacroiliac joint itself or that ligament. But those three risk groups, outside of those three, usually there's going to be some other driving factor that's causing the SI joint dysfunction. It's more often the victim than the culprit, right? And that's, as manual therapists, that's what we're looking for. We're looking for the culprit. We're trying to figure out how do we fix this problem over the long term. During your lunchbox. We're trying to figure out how do we fix these things over the long term? How can we get them to manage this on their own? And if we're just going through and manipulating the SI joint, or if we're just going through and doing some sort of muscle energy technique, or you know, choose your treatment path there, but it's not staying corrected, we're obviously not treating the keystone factor here. So I think in general, those SI joint lesions are going to be secondary lesions. You know, occasionally you may see something that's kind of out of the ordinary, but you know, those are the outliers, right? And you see the most common things the most commonly. So that's usually the best way to kind of have your mindset when you're starting to look at someone. Questions about that? No?
I mean, I would agree. I think the interesting was the torsion one you mentioned. I'm sorry. The torsion one you mentioned, I would kind of go along with that in a sense that, you know, the patients with scoliosis I tend to have more torsion-based things and respond well to the torsion manipulations in Module 5. And, you know, your innominate rotations are probably functional, you know, your functional long legs, short legs. And the SI joint, I would agree, is, you know, this is the SI joint section, so we're talking about SI joint, but the one thing I always want to preface, I don't put it at the front of my mind. I do think that this is sometimes the monkey in the middle, as it were. It's a secondary lesion, potentially. I'm sorry, Marissa?
I was just going to comment. I think what's tough and is a key like educational component with patients is that they're coming with SI pain. Like they're rarely going to tell you, hey, my thoracic spine hurts or my ankle hurts. Like that, I find the pain is mostly in the SI area, but you know, but you're doing your exam trying to figure out what the driver is. So I tend to find more STJ issues. Maybe I'm better at picking that up than I am at thoracic.
Yeah.
I don't know what's more common. That's kind of why I asked about, you know, maybe I see lots of runners. So I'm always looking a little bit more at ankles, and I think those are easy to pick up and treat. You know, patients love that long access ST distraction manip. They love it. They ask for it every time. They always want me to check it. So I think that's kind of an easy way to address a leg length issue.
The talar cruel manip or versus the
Correct.
subtalar joint. Okay.
Yes, that one. Yeah, well, all of it. I mean, kind of, yes, but yes, the long access one I find is helpful.
Yeah.
Yeah, and there's a couple reasons that could be too, because a long axis, either talar cruel or if you're doing it for a subtalar joint, if you overshoot just a bit, you can hit the SI joint as well. You know, so it ends up being one of those things like, oh, you know, are you alleviating some sort of mechanical dysfunction at the ankle or the subtalar joint, or are you also just happening to hit the problem that's going on at the SI joint? Now, when you're asking the question, you know, what's the demographic that you'd see a thoracic lesion with versus a subtalar joint or a talocrural joint subluxation, you know, narrowing it down to a group of people is a tough way to do that. You're gonna see more foot and ankle problems in runners, but I will tell you, I work with a ton of endurance athletes, so marathoners, triathletes, all that sort of stuff. I will tell you, they, as a population, have the stiffest thoracic spines of any kind of athletic group that I've ever seen. Universally, I have a gal that just competed in the Olympic trials back in February, and her thoracic spine, every time she comes in, is a bungled up mess. I mean, it is just rigid in most cases. And you'd think, you know, she's thin, petite, she's very fit, but her rib cage just gets all kinds of jammed up. And, you know, the question mark for me then becomes, you know, why is that the case? Well, my suspicion is that she ends up with some sort of motor compensation as she gets into some of these longer distances. As something starts to fall apart, she has an unstable hip. She's got a kind of a pre-diagnosed labral tear in her left labrum. She's also got some chronic instability issues around L5. So my suspicion is as she starts to fall apart and fatigues at certain areas in her gait pattern or running pattern, she starts to stiffen up. She starts to hold everything real rigid, and she starts adding in more mobility where she has it available. So she's putting more of that mobility into the hip. She's putting more of it into the lumbar spine. And so the thoracic cage tends to tighten up on her. It's possible that also as that stuff starts to go on, that her breathing pattern starts to change. She becomes more of an apex breather. There's all kinds of different things that you can kind of examine in order to go into that stuff. In general, I don't try it into a particular region of saying like, well, this person kind of falls into the typical category of having a thoracic problem, of somebody that would have a thoracic problem versus somebody that would have an ankle or hip. This is why we tend to promote the idea of doing screening tests for body regions in order to rule them in or rule them out. So for me, like I said, thoracic, just seated rotation. If you notice a substantial difference from one side to the other, and I would consider a substantial difference anything of greater than maybe 20% difference from one side to the other, now I know I'm going to have to examine the thoracic spine. Same thing with the hips. If I go in and I do a hip quadrant on the left side and I say, okay, that looks a little abnormal, let me check the right, and I notice a substantial difference between the two, now I know I have to examine that hip. Same thing with the ankle. If I can just go through and do active and passive range of motion on the ankle and I say, yeah, it's limited, I know I have to go in and do a full diagnostic there. So doing that sort of stuff just clues me in. Because I think you're going to be really frustrating yourself if you try and get to the point where you have somebody walk in the door, they kind of tell you about their situation and you say, well, you're going to be a thoracic driver person. You're going to miss too much by trying to do that sort of thing. Because even the patient themselves may be doing something kind of either functionally or habitually that they don't tell you about. And the only way you're going to find it is by actually going in and examining the body region. You know, somebody that comes in that's a runner comes in and tells you about all their running problems, but they don't mention that their their day job is that they sit in front of a computer with their forward head like this, which is going to obviously affect posture, and that's going to be most significantly manifested in the mid to lower thoracic, in the thoracic spine, the mid range of the spine. So they may not even mention that sort of thing, and you may notice it when they're sitting there, but you got to be able to kind of continue with some of that clinical reasoning stuff. I think trying to go in and set up a true demographic for one versus the other is a tough job for any PT. Does that make sense?
Yeah, what you'll see in a thoracic spine too is the thoracic spine is designed to absorb the compression in runners. It is a spring loading mechanism. It needs to be able to do this. So we get in that stiff model that Eric's talking about with thoracic spine is now stiff. What does that do? It transfers load as a unit. It's not absorbing forces this way as we're running. Now, not that you should see this larger vertical displacement in the shoulders, but the spine itself, especially thoracic spine, is a large amount of compressive load it can absorb. Again, if it's not doing it, it's going to accelerate the loading force into the lumbar spine, into the lower segments, and drive it down into the legs. So as much as you have the force driving in through the foot, you can also have that thoracic spine stiffen. And you see it in older runners as well. If the thoracic spine gets stiff, kind of accelerates the load through the spine. So they change a lot of their mechanics based on that as well. So you'll see it. So where you are now, Marissa, is that you know the ankle very well. I mean, that's easy. You're going to do that on a routine. We're going to start to do it. I'll probably send something else separate to the fellows that this is how to start looking at the thoracic spine to look for maybe, again, translatory lesions that may be kind of in there that may be influencing this. And I often think of them as the ring translation as more of a center of mass issue where I may be compensating for a rotated pelvis by that re-rotation. And it's not the jammed sublux translation. It's more that myofascial, that tightening. And we talked about the rotection, latection lesion, that segmental tone at one level with that rotation. It's also what Eric talked about is the forces driving up. You can have the iliocostalis, which attaches to the sacrum. And Eric talked about the one point in the innominate, where you also have the iliocostalis coming up, attaching thoracic spine, sacrum. So in that locking, unlocking mechanism, that can also be involved where you're going in there and they have these hypertonic, erectors every time you see them. Is it driving from the pelvis, or do you have a ring lesion higher up that may not necessarily be a subluxation? It could be just that ring is myofascially held tight, and you have that tight band of paraspinals coming down to it, and that'll attach to the sacrum.
And that's all end-feel when you're examining that. So in the video that Dave sent out this week of Gail and Fred going over the mobility testing of the SI joint, basically they're looking at anterior posterior rotation by hand. You'll run into these patients where you feel say the left side and it feels pretty good, everything feels like it's moving, and then you get to the right side and you're going into whatever direction it is, usually it's posterior rotation, and you say, well, there's a little give here, but it feels pretty limited. I'm just not getting as much excursion out of that glide as what I would expect. The idea that, I'm getting some movement here, but something eventually is blocking me, that doesn't sound like a true pathomechanical feel to it, right? It doesn't feel jammed. It doesn't feel like there's that kind of crisp block there at the end of the motion. Those are the ones that I tend to think like, what I'm running into here is I'm running into muscle tone as I'm going into that, as I'm trying to rotate the innominate and the PSIS is going down toward the legs. That's where I'm running into that restriction. And it's just that tone that goes up into the thorax. That's what's preventing that posterior rotation. And you get used to it if you don't come in too hot and heavy on your glide. So as you're doing these things, if you're not kind of doing something too quickly, as you kind of ease into those glides, you tend to be able to appreciate what the end feel is like. Is there some give there, but a restriction there at the end of that? Like I said, that tends to be more of that myofascial end feel to it. It's the same as most other joints. You still have to kind of try and appreciate that sort of thing. I think we tend to get into this with the SI joint. We get into this realm of, is it fixated or is it not fixated? And there's more realm to that than we tend to kind of appreciate a lot of times. And you can certainly have capsular lesions of the SI joint. It has it has a joint capsule around it, and you can have you know, ligamentous scarring and all that sort of stuff as well. I tend to believe that in a lot of cases that the motion that will tend to be most restricted with a capsular lesion is more the horizontal motions, in flare and out flare, as opposed to anterior posterior rotations. Now, similar to what we talked about with the ulnohumeral joint in our module 4 course, is that if you have, you know, an ad or abduction lesion, it's going to affect flexion or extension simply because the joint's not tracking properly. So it's going to affect the amount of mobility that you have there. So similar with the SI joint, if you have an in flare or an out flare, then it's going to affect anterior posterior rotation. How that couples is up for debate. You know, I could give my opinions on it, and I'm sure Dave has his, and I'm sure Gail and Fred probably each have theirs. Well, Fred probably doesn't have his because he doesn't look for in flare and out flare, but you know, everybody tends to see them in coupling a bit differently. But that's where I usually will tend to see that is in that like post sacroiliitis patient. I'll tend to see more in flares and out flares with somebody that I know has had an inflammatory reaction at the SI joint than in somebody that's had the pure rotational lesions or the torsional lesions. And those people are usually easy to pick out. You know, they come into the office, you do your primary stress tests, and you know, that hurts, it reproduces their pain. You say, okay, you know, first order of business here, calm the tissue down, get the acute pain out of there, get the swelling out of there. And after that, I know I'm probably going to have to toy around with some of these in flare and out flares. And it's just because it's quote unquote more of that post-inflammatory reaction, it's more of a true, like, this is a capsular issue or something similar because it may be more ligamentous scarring. It requires passive mobilization, graded mobilizations to fix it. So I tend to see that more. You know, maybe I'm oversimplifying some of these things, and like, you know, like I was saying, trying to put these things into a box so that they make sense in my head. But it hasn't driven me wrong yet, so I'm going to keep doing it as long as it keeps working. And we'll go through most of this stuff for those of you guys that haven't done, you know, the pelvis stuff yet. We'll do this all in module. Was it 5? It's 5 the pelvis one? Yeah.
Yeah. Yeah, the SI joint. That's kind of, you know, we just saw in the video I sent out, and if you haven't seen it, that's okay. You can take your time and go look at it. And that's the assessment that you'll learn with Eric going into module 5. We're just gliding on, just basically pressing down on the ASIS and checking the relative end feel. I think one of them, they may have put their hand underneath it and felt the sacrum and felt the relative motion, putting my fingertips on the sacrum and then coming in and rocking it is one way, or just pressing down on it. And on the one example that was sent out, it was nice because I liked it because it wasn't a stiff segment. It was one that moved excessively. And it's kind of nice to kind of reemphasize that, because we get so in our mind, as Eric said, is stuck, unstuck. When really what we're looking at is, what is this system giving me? Is this system giving me a little bit too much? And in hers, it was the right one. And again, that's where it goes back to instability, probably similar to the patient that Eric sees, is that this SI joint is moving too much. Is this SI joint a primary in her, where she's counter-nutating when she hits the ground because she can't stabilize it? Is it because the excessive forces coming in from the ankle have now done it to it? Is it coming from above in her stiff thoracic spine, driving down into her pelvis? And is her system losing control? But one thing I know is that she needs to be able to control that SI joint in the video you're seeing, and she's not. And it doesn't mean that she won't be a good runner or an elite runner. It just means that, you know, these drivers, as long as they stick around, she's going to have the reverberation of problems in different places. And you'll probably see the muscle dysfunctions in her. If we see the collapsing hip, we're going to see the loss of internal, external oblique control on the opposite side to hold that pelvis up. So you'll see the muscle balances around this right side of lack of control. And the one takeaway is, if I want to check her muscular stability at that joint, and they didn't go into it in the video, what usually controls the upper portion of the SI joint, sacral base, is multifidi. The sacral multifidi attached right there, they should be thick. If we palpate her and it's not very thick and it's very soft there and underdeveloped, then I know, okay, this is an inhibiting system there. If they're hypertonic, then they're hypertonic and not functioning well when she needs them. So with the video that's there, take a look at it, look at the right innominate, kind of move too much. Both Fred and Gail find the same thing. That would be the next thing, is check the multifidi there. Because if you get her to contract the multifidi, it should stiffen that joint. And that shows me that I have good force closure at that segment. If it's the infralateral angle, I think is moving, or I have a controlled problem there, that's usually pelvic floor. You can have them basically contract, do a pelvic floor exercise, and you should be able to feel the infralateral angle mobility, or that downward glide on the pelvis should tighten up if they activate the pelvic floor. So that's just a little extra one in there. For those in M5, don't worry about it. For the fellows on here, we'll go over it a little bit, give you a little bit more how I can use muscle activation to change my SI joint end feels, depending on what I'm feeling. And that's what also what Eric talked about is great, is that this end feel feels stiff, but it's not quite jammed. So do I have a muscle activation pattern of pelvic floor, piriformis, or multifidi occurring at my SI joint? Does that make sense, Eric?
Absolutely. You know, and I wanted to mention this earlier. I kind of got off track a little bit, but you know, in the video that Dave sent out, we see this patient that has what kind of looks like this real hypermobile. It's her right innominate on the sacrum, and you know, the question mark is well, you know, how does that happen? You know, how do you destabilize the sacroiliac joint? Well, I mean, one way is you have inflammation in the area. The inflammation gets into that fibrocartilage pad and chews up the pad, right? And so that thing that should be nice and thick now kind of starts to shrink down, and now all of a sudden we have all this extra play to it. You can get subluxations of that where it's just like the thing kind of just goes past the end of the neutral zone and kind of jams into that pathomechanical barrier. The other possibility, and this is a lot of what Dave has been talking about the last couple of weeks now, is in general when we have so if this would be, I guess it'd be the left person's left innominate and the sacrum here, right here where the sacrum is nutated forward, right? So into this position there, or relative posterior rotation of the innominate, that's where this is what we call form closure, right? So where the joint is actually kind of fixed in there based on the structure and the shape of the joint. If we have a patient that comes in that has an anteriorly rotated innominate, right? So if they have a leg length discrepancy that's driving this into that kind of innominate rotation anteriorly, that unlocks that sacroiliac joint, right? And so now when we put our body weight down on that, if you think of the vertical loading coming down through the spine here, or you think of the ground reaction force coming up through the leg here, we're going to get this sort of thing, right? Now we're going to destabilize that sacroiliac joint because we're putting an abnormal vertical shear through that joint every time they go through weight bearing. Any joint in the body, you put enough abnormal forces through it, eventually it's going to destabilize in that direction. So, you know, outside of having somebody come in and say, oh, I've got, you know, Anki-Spond, okay, well, you might have an unstable sacroiliac joint. We're going to have to do some, you know, stability retraining. We may have to think about some, you know, external supports, things like that. That's definitely a possibility. But in these people that come in, they're just like, I don't know what the hell is wrong with me. And, you know, they don't have any other symptoms of some sort of systemic inflammatory response. It's very possible that this is one of those, you know, quote unquote, micro trauma things that's just started to wear out some of that, those secondary stabilizing factors, like the ligamentous controls, because the primary stabilizing factor of the SI joint is the form of the joint, right? It's a wedge. It's supposed to wedge in there. But if it's not locked properly, if you're not getting proper nutation of the sacrum, it's going to be unlocked when you put weight on it. And then that's going to create that kind of vertical shearing. It's a very common way that people develop pain along the SI joint, that Fortin's point pain. Very common that you have that sort of thing happen. So the question mark is, why did it get that way? You know, was it the leg length problem? Was it something pulling from above? Is it a torsional issue where you have something kind of coming out of the lumbar area? Is it a muscular incompetence problem where you have, say, a radicular lesion or some sort of facilitation where it's a speed dependent problem? Any number of these things come into play. But it's good to kind of have that idea that it's not just, like Dave and I have been saying, it's not just stuck or normal. You know, there's a gray area in there. There's muscular restrictions. There's capsular or ligamentous restrictions. And then there's the idea that that could be hypermobile or even unstable. So, you know, for those of you going into Module 5, we'll get into all the secondary stability tests and kind of how to assess that sort of stuff. But for the fellows on here, always good to be reminded, because I'm sure we have talked about this stuff at some point, that there's more to it than just, we need to move it this way or that way. There's always these greater, more long-term complications where sometimes we have to go in and find ways of stabilizing these things. Questions? Not talking from too high up? Tend to do that.
Marissa, for $200. Just unmute yourself. You have a question?
No, that was my 9-year-old tan. Sorry.
Oh, okay. Fair enough.
So Marissa, you asked about the best way to assess pelvic floor.
Well, I just mentioned that because I usually will just try and, besides the history, right? I'll just try and do a TA, palpate it at the level of the TA when I ask them to do a pelvic floor. I just had never checked it before with the way Dave mentioned.
Yeah, so here's an idea, and this is the way that I'll assess pelvic floor if it's, an undiagnosed thing, and, I think it's a possibility. During our forward flexion sacroiliac kinetic test, the one where we're looking for it to drop down and then go up and all that sort of stuff, the first phase of that, where we should see if this thumb here, my middle thumb here is the S2 and this side is on the innominate, the first step that we should see there is we should see the S2 drop down, right? And then after that, we see the pelvis move, and then we see everything move together, correct? That initial descending movement of the S2 is due to the tightening of the pubococcygeus. Okay, so that should give us a pretty good indication. If you're missing that first stage of that forward flexion test, the pelvic floor is not recruiting properly.
That's helpful. Thank you.
No problem.
Hey, Leslie, do you work with pelvic floor patients?
Sometimes I do. My last clinical rotation was with a pelvic floor specialist. I know a little bit of recruitment, but not many here.
Yeah, I just didn't know if you had anything to add to the conversation on testing for pelvic floor.
We see it in a lot of SI joint pain, but I usually see it post-pregnancy, so it's normally we know it's an issue diagnosed. So.
Any questions? All right. If you have questions, just send them or interrupt me. The only other thing probably really cover would be is the concept of neutral zones, which are in the slides, and there's a section on module 5 on there, and Gale slides. And it's nice to cover because I'm not quite sure how deeply you get into it, Eric, during the on-site. But we're talking about SI joint this is what we're talking about, the variations in neutral zones, and that's the exact discussion we had today. Is that normal neutral zone has a normal length to it. And that's the area where the ligaments and the primary restraints aren't really inactivated before we start to get the capsules, ligaments, tendon restrictions become involved in that. And in the pelvis, we look at the one video that we sent out where the innominate was moving too much. Well, we have an excessive neutral zone there where this thing is moving all around, and that, we have excessive neutral zones where it can be lax because the system starts to break down. Because of, as Eric said, you have the cartilage breakdown in the SI joint. Now all of a sudden you have a very lax neutral zone. It's been increased, so now it increases the forces toward the end range zone or instability. There, it's where you can have that can lead to your subluxations. It can also lead to all your soft tissue breakdown around it, and also your motor control problems. So, the concept of neutral zone kind of seems like this foreign thing, but you realize that we've discussed basically all the different neutral zones today in this conversation. Essentially, at some point between Eric and probably myself and everyone else, we've mentioned them. There's increased muscular tone or hyperguarding can decrease the neutral zone, and that may be the runner that Eric's seeing in the thoracic spine. This girl is searching for stability, and she's hypertonic throughout her thoracic spine, and she's not flowing through moments where she needs to have rotation and motion and then be relocked at certain points in loading, and she's not doing that properly. She just uses a strategy of complete stiffness. It's going to be an increased load transfer into the lumbar spine and other segments. So that's an area where the muscular system has now decreased the neutral zone in there. Your jammed subluxed joint could certainly do that as well if we're talking about a decreased neutral zone. I have a joint now which is jammed at its end point and being held there through stiffness. That's probably the breakdown in the joint. So that's probably the person who has that increased neutral zone in everyday life, and then they're jamming on an end, as it were. So do you guys have a good concept of the neutral zones and kind of even what we talked about today, or at least starting to? Because we talked about it a lot, we just didn't talk about it.
The one thing I want to ask is how much does it relate or overlap with when we think about like close packed and neutral packed, or close packed and loose packed, excuse me?
I'm sorry.
Well, you can think about that in any joint in the body. Close pack is just the tightest position of any joint, right? So that nutated position I was talking about, there's not necessarily a particular position of the pelvis that will get you into a pure close pack, because you can be in kind of that posterior rotation of the innominate or that sacral nutation position in various positions of the trunk or legs, right? But in general, loose pack is just any position that's not close pack. Now, most joints have what they call a least pack, where it's the loosest or the rest position, however you want to describe it. The sacroiliac joint doesn't really apply to that because of that intra-articular ligament. So it's going to have a lot more stability in its quote unquote loose pack or less pack position than most other joints in the body. But if you think about it, anything that's non-weight bearing and anything with the innominate in a relative posterior rotation to the sacrum is going to be considered a closed pack position of the SI joint. So that position when the leg is swinging forward as you're going toward heel strike, but the heel hasn't yet hit the ground, that's going to be the tightest that SI joint gets.
Okay.
And it should be, because now it's about to hit the ground, right? Now you're going to have that impact, has to be able to absorb that somehow.
I guess my question was going to lead towards some go-to motor control exercises or exercise progression for when you have an increased neutral zone. I mean, a lot of us kind of fall into whatever camp we came up with. If we're into, neutral spine, TVA, posterior tilt, PNF, everyone kind of gets in their camps or falls back on muscle memory. Sorry, bad. Anyways, if you guys have any advice on that.
Yeah, so for stability stuff, on the website or on the Moodle site, I know Dave has posted, I think Scott actually wrote it up. There's a good thing in there on instability. He relates it more to the spine, but you can use it for the SI joint. The only difference is you have to take into account the pelvic floor a little bit more. So that's a good reference. I think it's in the thoracic module, but I'm not sure.
It's not in the fellows will have it. The current group it was taken out of, as they limited some of the content for the current group, so they won't have it. But
the reason I like that is because there's more reasoning behind it than just this is what I used to do. For me, when I go through and trying to do these sort of things, I still like to use actual muscle testing in the clinic to see where things are falling apart. For the SI joint, the kind of the three biggest things that are going to kind of come into play are going to be the biceps femoris, glute max, and the paraspinals, so the multifidi. Those are going to be the three biggest stabilizing factors. Now, if you want to get into specifics, we're really dealing more with the short portion of the gluteus maximus, which is really only about a third of the muscle. That's the portion that goes from the sacrum to the femur. The more substantial portion, I think it's 2/3 of that actually attaches from the thoracolumbar fascia into the IT band. So you can kind of narrow those things down a little bit more depending on what you're trying to accomplish exercise-wise. Those are the three groups that you really want to try and focus on initially. Recruitment for me is number one. So I want to use reflexive activation. So anything that's going to get those muscles to turn on automatically, but that's not going to put the patient in a position of either discomfort or some sort of dysfunction, because if you put them in a position of dysfunction, they're going to have a hard time recruiting that. Kind of the number one exercise that I like for this is that we call it a golfer exercise or a bird dip, where you essentially have the person stand on one leg, take their hand, and then they reach down for their opposite foot. That'll recruit the hamstrings, that'll recruit the glute max, that'll recruit the paraspinals. You can add some load, just have them hold a water bottle or a couple pound weight, something like that. That's going to very much be a very nice reflexive activation of that. If they can't tolerate the bending over, the next one would be like a single leg stepping up and kind of reaching toward the wall. So that'd be kind of this sort of thing, reaching with the same side arm. That's going to recruit the multifidi very well. It's going to get the hamstring to turn on because of the single leg recruitment. So anything you can get to do there just to get those things to fire is step one. I'll usually, if they're in a pain state, if it's hurting them currently versus just being dysfunctional, you got to kind of work through that stuff until the pain state dissipates, and then you can kind of move into what I'd consider more of a endurance phase, where you want to get these things to recruit long enough to transition from one set of motor units to another set of motor units. I think we talked about this a couple of weeks ago, where the idea that a typical muscle contraction uses only 60% of the motor fibers available in the muscle, and those other 40% are held in reserve for either sustained or repeated contraction. So being able to break through that initial 60% and get into that next 40% usually requires something that I usually describe as a tempo repetition or a tempo set, where you increase the duration of the concentric and the eccentric activity. That'll blow through that initial 60% and get into your next 40% pretty nicely. You can do kind of anything with that. You can do isolation exercises for the hamstrings, or isolation things for the multifidi or the glutes, bridges, etc. Those things all work well. But once you get past that and you're kind of into the management phase, it kind of will depend on the patient's activity that they want to do. If it's something that requires some sort of speed dependence, like a running or jumping, then you have to ease them into that sort of stuff. But for something like the multifidi and the glutes, because of their need, because of the glute size, and two, the actual diameter of the multifidi actually have to be able to fill in that, we consider it like an osteoligamentous tube. So if this is the backside of the vertebra, and here's the spinous process, and this is the transverse process, we have the thoracolumbar fascia overlying that. So it kind of makes this tube almost in here. And the multifidi has to be able to, when it contracts, it has to be able to expand and compress those tissues, and that helps with kind of more of even articular stability. It makes the spine more rigid, and it does the same thing across the sacrum. So if there's not enough actual cross-sectional area of the multifidi, you actually have to bulk these things in order to make them stronger. So actually having a true quote-unquote strength phase. Doing that, depending on the patient's situation, could just be a time under tension thing. I do a lot of high repetition things, tell them like, you're going to do this until you get to 100 of these things with good form, go. And, something along those lines, just really build up the amount of time that muscle belly is under tension. That'll increase the muscle strength, even though you're not adding true load. Because in general, you have to be able to add load in order to increase strength, increase the muscle's power per se. But in a lot of these patients, they're not able to do that stuff. But you also need to go into some functional stuff. So when we look at functional stability of the SI joint, we're dealing with more diagonal motions here. Again, this is mentioned in Scott's little manual, but I think I have it in some of the stuff that I use for Module 5 as well. Using the idea of these quote unquote functional slings. So these are muscle synergies that actually crisscross the sacroiliac joint. So when you're looking at the sacroiliac joint, it kind of sits in this little bit of an oblique plane. If you're looking at the lats coming down from above and getting into the thoracolumbar fascia, that all blends into the glutes going the other direction. And by the time it gets to the SI joint, it's directly perpendicular to the joint. So it actually creates a compressive force there. So being able to synergize those two muscle units, something like a bent over rowing motion where you would load the glutes by bending the knees and putting some weight on the hips, and then doing some sort of rowing motion like that, either with the band or with some small weights, cable machine, any of those sort of things, they all work well. But then the next synergies there would be the posterior sling. That's again that hamstring coming up and across the paraspinals. Anterior sling would be the abdominals and the adductors as they cross the pubic symphysis. So finding ways to do that, I usually will have people do kind of just sit and lean back and do some rotational things. They squeeze a ball between their knees. And then there's what they call the lateral sling, which is actually the gluteus medius and the quadratus lumborum. And that's more kind of this sort of motion going side to side. That could be anything from a side plank to, a monster walk or a banded lateral walk, something like that, with while holding a weight on the side, something like that. But that's kind of the progression: recruitment, endurance, strength. And the strength phase is usually where I'm getting into those functional activities, like using those slings in order to try and get the patient back to more of the way we actually operate in life, because we don't tend to operate in these straight planes, right? We're not doing these sort of motions day to day. We're in these sort of planes. Everything's diagonal. That's how these things are connected. So if we can't synergize those things, functionally speaking, we could have them doing all the, transverse hollowing and bridges and things of that nature that we want, but they're going to fall apart when they get into the functional tasks if we don't have them treating that as well.
And that goes into the initial phase of being, like we talked about initially, where's the failed load transfer? And we're talking about SI joint today, but in these cases, what we can talk about next time is how we integrate the hip in the failed load transfer, because that was the first thing we talked about. Innominate slips, hip rotates. Now all of a sudden my muscular system is going to be turned off. So I can do all the prep work. I use a little bit of Shirley Sauerman, Stuart McGill, and I kind of blend Hodges work together in my base package, like a phase 1, maybe phase 2 of a back program. I think the motor control patterns are all there, but if I stand them up and I'm getting that failed load transfer through the leg and I don't address that, then my exercises then just become kind of exercises for the endurance aspect of it, but I may not be addressing the motor driver of it. So there's the endurance portion of it that we need. We also need to make sure we're addressing, again, the motor control. But if I'm constantly having a failed load transfer with a very fast internal rotary moment, we're gonna collapse. So if I'm looking at this person in a single leg stance, like with the single leg basic deadlift or hinge that Eric talked about, they need to be able to control the pelvis in the back. So I need to make sure that they have fine control of that muscular system isn't slipping, and that I'm not getting a shear force, so the L5S1 isn't flexing abnormally. I'm not getting an aberrant motion there. And then from there, it's endurance. Kind of like Eric is picking out activities. I always looked at it this way: is I know all the back exercises. I need to get you moving well, and then I need you to do it for 40 minutes or more at that point to get work on endurance. But motor control is the other element of it too, between double leg stance, single leg stance, rotational patterns, other movement patterns, is to say, once I have this system set, I can control the failed load transfer, whether it's stemming from the ankle joint, if it's Marissa's patient and they're subluxing, and then now I can control the hip and SI joint, then it's rolling that back into the motor control patterns and keeping them active. That's why, many exercise progressions and models appear to work very well. But we are in thin slicing. When is it the motor control is off? When is it the joint not being controlled? And how do we do that? So as part of this program, that's the cool thing I want you to think about learning, is you're not learning how to basically manipulate joints. That becomes the easiest thing we do, is understanding where is that failed load transfer? Why is that slipping? Why is my neutral zone off? And how can I address it? Then your exercise progressions are all about, I can stabilize that segment that's giving me the problem. Now let me get the motor and the muscular system to activate properly around it.
Yeah. That was the thing that I missed the most when I was doing my fellowship work, because I did it with the North American Institute before impact was really a thing. And it was really good for teaching you how to do all the hands-on stuff and all the examination stuff. And, all the theory was great. But as far as being able to maintain these things, there was not enough of that sort of stuff. So, I think we're getting better at this sort of stuff, kind of getting into these things as far as, how to maintain this stuff. But, we want to be consistent with the idea that, hey, scientifically speaking, you gotta be able to associate some of that sort of stuff in order to make it the most effective that it can be. As like Dave said, most people can go through a Shirley Sarman routine or a Robin McKenzie routine with a patient, and they'll walk out of the office feeling pretty good, but as soon as they go back to activity, they fall apart because they can't get it back into their proper load transfer. That's why I think a lot of patients end up with these things kind of so chronically and so intermittently, is that they never get to that stage. How many patients do we have on a regular basis that come in for 3-4 weeks and they're like, I feel great, so I'm just going to handle it, and then they come back 4 months later with the exact same problem because things fell apart again. That's another challenge, but again, being able to relate why you're doing something and having a reason for everything you do in the clinic or reason for everything you're having a patient do at home, it's a good idea, because at least then if they say, I don't know what this is supposed to do, you can say like, well, this is what I'm trying to accomplish with that. Because you want to be able to build that trust with your patients too. If you can tell them like, well, this is the very specific purpose that we're having to do this, they're more likely to do it.
We've got the laundry in the dryer and bring it up.
I'm gonna have to jump off. I've got my kid with me and I got to take him home to finish up his schoolwork. So I will see everybody next week, I guess. Yes.
Clean up any questions, and we'll go next week if you're good for it, Eric.
Yep, we'll do that.
Yep. Sounds great.
All right, Dave. We'll see you guys later. Have a good week.
Thank you.
Justin put up a link for basic progressions for oblique sling concepts in the chat section, so you can copy and paste that link if you like. And I work with Justin, so Justin and I go over this stuff, a fair amount, and that's what we kind of did this morning. And we'll probably do the next time is I'll try to emphasize the hip a little bit more, and if you guys want to think about just other models like ankle, long leg, thoracic spine, we can do that. But we talk about failed load transfer. Maybe we'll get into the pelvic hip synergy. That kind of goes back to even when we talk about just the stabilization progressions, because Justin and I were watching a young girl today who had an ACL tear. This was remotely probably 2 years ago, and some other issues. But we were watching her in a half kneel position, and she couldn't control the half kneel on the left knee. She was all over the place doing any kind of crossing rotary pattern. So we look at her SI joint and hip, and it was, she had some, she had that failed load transfer pattern in the SI joint driving it. So then it's chicken or egg. Was the ACL, due to this pattern being there all along, or is this pattern left over from an ACL? But either way, it's somewhat related to, how she'll be wonky now, and that needs to be cleaned up as she goes forward, or else she'll just continue to kind of fail and turn the system off. And her hip, Justin, too, was that stiff hip we talked about, not the one that was subluxed, but you could tell that her internal rotation was less than the left.
Yeah, her left hip was kind of stuck forward in that kind of Ufer model, and it kind of took the innominate with it. So she was kind of stuck into that kind of anterior rotation. And anytime she was on that left side, which is the side that she had the ACL on, she would uncouple the SI joint, so it would unlock on her. So if she was squatting or lunging or stepping, she was getting unlocking on that left side. And like what you guys talked about earlier, you started to see that hip spin in, the innominate would drop, and she'd get valgus to the knee.
So did she have a non-traumatic ACL tear?
It was non-contact, but I mean,
Yeah.
It probably happened. She's probably like 3 or 4 years out from that now as field hockey.
Yeah. So then that would kind of make me guess, like you said, Dave, is like that was probably present at the time that she tore it.
There's a good chance she wasn't stabilizing well. You never know, but you can look back on this, because it's a long-standing pattern. And again, you can see that pattern was never cleaned up. And again,
you'll see this with a lot of knee patients. If you get your knee patients, because of what the patient will do to kind of try to stabilize that knee, we'll start moving through that hip and that innominate a little bit differently. So you'll see that kind of uncouple a little bit on them. So I think Dave had a patient a while ago. She was actually rehabbing from an ACL injury. He was just starts complaining about her back. We took a look at her back. She was all jammed up. Just all the things she was doing to compensate around that knee to kind of get stabilization in it.
That's kind of what my question stemmed from before was you get all these microtraumatic causes when we know that the SI joint is more than likely the secondary issue. But we're talking about the SIJ being what they complain of pain of.
Yeah.
But if we're seeing that instability, or let's go with an instability model, that's really the problem because of all these, like, that might not be where they have the pain, but what would, I guess you're looking at all the lower extremity things that are painful that are normally the primary cause. So then what would bring me to look up at the SI joint?
You're really going to look for load transfer. You're going to address your main problem. They're there for a knee. At some point, and depending on that patient, I'll look at the first session or second session.
Okay.
They're probably rapidly internally rotating from the hips. That's really easy to tie into. You're getting a twisting motion at your knee because of your hip. So we're going to take a look at your hip to see this rapid internal rotary motion, which is beating you up. It's coming from here. So let's go and look at the SI joint and hip, then try and determine
other components of that rotation.
Yeah. Okay. Then you see, okay, if I tune up the hip, does the SI joint then stabilize? Then the hip is probably your driver. Hip fires better, glute activates, SI joint has force closure, SI joint shores up.
We talk about like stabilization. I think one of the reasons stabilization is so hard about a joint is it's typically some sort of compensation for something else that's not doing its job. So if we have that patient that's valgusing through the knee every time that they squat, again, we're going to look at the ankle. We're going to look at the hip. We're not just going to tell them, hey, stabilize your knee. So I think that's when you're going to go back. All right, they're having a failed load transfer through the spine or through the SI joint. All right, now we need to look at kind of everything around that system. So we're stabilizing their knee, but the way that we're doing it is making sure that they're biomechanically or functionally sound. So it doesn't always have to be like an exercise you give them. Sometimes it's like, you're going to correct the hip, and that's going to have a 50% stabilization effect on their knee.
Sure.
And all of a sudden they can hold that correct position. So think about it as kind of part of your stability program, making sure everything else is kind of sound.
Cool.
Good. All right. Continue to let us know what's helpful and what isn't helpful with these. I want to make sure that these are valuable to you guys and that you're kind of, doesn't become rote to you. So just let me know if there's more you want, less of something, and we'll try and incorporate and morph these to kind of meet what you want. All right, and we'll pick on Ashley more next time. She sat there quiet the entire time on her phone. No. All right, with no questions, hey, feel free to email me if you like. If you have any questions in the interim, you want to do it off of here, I'll try and address it or get to it. Anything we do for you, just let me know. Okay?
Thank you.
Report we'll do next Wednesday.
Later, guys.
All right, take care.
Thank you. Take care.
Thank you.